Cardiac rehab obviously is very important, and it saves lives, and everyone in this room knows that. We also all know the challenges with the current delivery model for cardiac rehab in terms of access and people being able to do cardiac rehab. And so, we've been coming to this conference for the last 4 years, and we've been talking about home-based cardiac rehab. And I think now, with the scientific position statement from the American Heart and AACVPR, it's clear that home-based cardiac rehab is a viable alternative to center-based and is here to stay. But there are lots of questions around how do we implement it, how does it get reimbursed, how do we make sure that patients are safe when they do cardiac rehab at home. So as a company, Moving Analytics, we're focused on this problem. We've developed a program called Moving. It's a digital cardiac rehab program. It's based on lots of research from Stanford on how do you do cardiac rehab safely at home. And I'll just give you a very high-level overview of how it works, mostly from an educational perspective, so that you kind of understand the context to the questions we'll be asking the speakers today. So in terms of what you need to implement a home-based cardiac rehab program, I think there's a couple of things. One is having an evidence-based curriculum. So this is kind of how do you do home-based exercise prescriptions, how do you do home-based hypertension management. We provide a suite of curriculum for you. We also have the technology platform in terms of the apps for patients, the dashboard for the staff, the different devices that integrates with the program. We provide the clinical training because home-based cardiac rehab is very different from center-based cardiac rehab. And sometimes people think they can just kind of do the same thing at home. And so there's some training that goes into it. And we also provide a network of nurse care managers. So if you have a program that's already busy, you can actually use our nurses to deliver the program. But the unique thing about home-based cardiac rehab, sometimes when I talk to a lot of professionals, people kind of ask, is home-based different from, is it as good as center-based, or is it better? I think that's kind of a short-sighted perspective sometimes, because I think the goal of home-based is really for it to be another alternative for patients who can't do the physical program. But I think home-based is also very different and it's very unique. And we like to think of it at Moving Analytics as more of like a concierge model where you have like a dedicated nurse care manager who's, or cardiac rehab professional who's kind of guiding the patient on a personal one-on-one level outside of the clinic on how they manage their risk factors versus, a traditional program. But with home-based, and our program in particular is very comprehensive in terms of it does focus on exercise, but it also looks at other risk factors like, managing hypertension, making sure patients are on the right medications, helping them with smoking cessation and things like that. But when you think about how you implement a home program, and you see this when we talk to the speakers today, there are different types of staff you need, to deliver a program. So one is a kind of a program coordinator. This is someone who is responsible for recruiting the patients, getting them set up, showing them how to use the devices. The goal is to really get the patients into the program. And then you have a care manager who is someone who actually does all the ITPs, the risk factor management, training, and education. And you also have a medical director. And we'll talk about kind of how all of them are involved in delivering a home-based program. So in our model of home cardiac rehab, the first step is a program coordinator recruiting a patient. So they have like a dashboard that looks like this, and they use that dashboard to identify patients who are eligible, sometimes to identify patients at the bedside before they leave the hospital. Sometimes you do it after a cardiac clinic visit. Sometimes it's in the cardiac rehab program. But the whole idea is you screen the patients based on inclusion criteria, and then you have them complete different forms. Then patients go into like an onboarding where they get the link to download an app on their phone. And then the care manager introduces themselves to the patient, and they give them an overview of the program. And they also have the patients complete all the different questionnaires like the PHQ-9s to get a baseline of how the patient is doing. And all of that kind of helps the care manager develop a treatment plan. So home cardiac rehab follows the same, guidelines by Medicare in terms of how you deliver cardiac rehab. It's just done in a different way. So we still have ITPs for this patient in terms of how they do the program. And then every patient gets a kit. Now this kit is a function of the patient's risk factor. So every patient gets an app on their phone. They get a fitness tracker If they are hypertensive, we'll give them a blood pressure cuff because I'm going to be tracking their blood pressure. And if they have heart failure or they're overweight, we'll give them a scale. So this is all included in the kit, in addition to some medication booklets. And then they get the app on the phone. And the app really is a tool that guides the patients through all the things they need to do every day for their rehab. So they have a to-do list, they get reminders, they can watch different educational videos, they can communicate with the clinical team, and you hear more about that in the panel. And the way we do the sessions in home-based cardiac rehab, that's one question that comes up is, how is a home-based cardiac rehab session different from a face-to-face? In our model of cardiac rehab, it's really about self-management. So in terms of empowering patients to be able to manage their care at home. But we do education via weekly telephone calls or video calls. And so during these calls, we're going over patient education, we're going over their data in terms of how did they do their exercise, their blood pressure, the weights, and we're providing emotional support. So we find that a lot of patients have things that are happening in real life that can be in the way of their care and progress. And so during these weekly coaching sessions, that's where we do a lot of the face-to-face interactions that you're typically familiar with in brick-and-mortar cardiac rehab, but we do it in a home-based setting. And the system generates alerts when people exercise at home and they have like high blood pressures or they have heart rates that are going outside of the ranges. The app notifies both the patient and the cardiac rehab team that they need to intervene. And we do 30-day ITPs, so at every 30-day, we're generating a progress report, and we're also redoing the ITPs for the patients. So in our model, at 90 days, patients graduate, and then they go into, they have the option of doing a maintenance program. And so the difference between the maintenance and a core program is, in the first 90 days, the patients get weekly coaching from the care managers. In the maintenance program, it becomes a monthly check-in. So we kind of check in on patients once a month instead of weekly. But the patients still get all the remote monitoring, and they can always ask questions to the care managers. So this is a very high-level overview of how the model works. And I wanted to share this just so that we set the stage and you can understand how home-based cardiac rehab works. But to get into the panel, I'm going to introduce Heather Carey. Heather is the manager of home-based cardiac rehab at Kaiser Permanente here in Portland. And she's been a phenomenal professional to work with. I met her 2-3 years ago. I think at this conference, she heard about us and she reached out, and we were able to work with her and the leadership team that are here to get that program implemented. So Heather, if you come on the stage, please give her a round of applause. The other person that's going to come up is Anne Gavic. I'm sure many of you know Anne. She's a big cardiac rehab thought leader. She won an Innovation Award last year, and she's been also a pleasure to work with. I think one of the things that's interesting with home cardiac rehab, it's so new, and no one knows all the answers. But what's more important is having people you work with that have the right mindset. That's about, we're going to figure this out, and it's a collaboration between the company, the vendor, and the clinicians, and the patients. And Anne has been very, very dynamic and flexible. So Anne, please come up.
So I'm Heather. I work at Kaiser Permanente, and we just got our home-based cardiac rehab program off the ground at the end of May, beginning of June. We consist of 2 care managers and a medical director, and a really awesome practice director who got us going. And we are slowly intaking about 12 patients a week, and we're going to start ramping up now that we've kind of jumped through all our hoops with the organization and really start adding some more patients. So.
Cool.
All right.
Can everybody hear the mic?
Oh.
Okay, so let me just make sure. Hello, hello. So maybe just speak louder.
Just louder. Okay.
Yeah, but
Okay.
we'll just give it to Anne.
Almost kissed the mic.
Like a rock star. Hi, I'm Anne Gavic. I'm at Northwest Community Hospital, which is northwest of Chicago. We are one of the, I think, few medical organizations that's still remaining independent. So we are an independent community hospital. but we have about 444 beds, so it's large for a community hospital. We have a large traditional cardiac rehab program in pulmonary, and really our model, different from Heather's, is that we continue with our traditional model, but we were really looking at a way to increase capacity and decrease wait times. So I'm sure we'll talk about this more later, but that's kind of where we're coming from. So I have a multidisciplinary staff of 18 people, which is about 10 to 11 FTEs. And we have a large program of about 150 patients coming and going at any given time in our early outpatient program, but really, again, we were looking for a way to serve a larger audience. So that's really where we started partnering with Moving Analytics.
Cool. So I think you've kind of answered the first question. So for Heather, what motivated you to look into home-based cardiac rehab?
So,
So the question is, so if you see the screen, so how this is going to work is there's a question on the screen, and they're going to answer it. So the first question is, what motivated Heather to look into home-based cardiac rehab?
So Kaiser has always, at least Sunnyside, has always referred patients out to external programs in the area. We didn't have our own program yet, and I had done inpatient cardiac rehab at another hospital system in town, and then came to Kaiser when they opened their cardiac surgery program, and was wanting to refer patients, but the culture wasn't really there yet, and so, gradually people came to accept a little bit more, and I would send patients out, and a lot of them just couldn't afford to go, or didn't have the time to go because they worked still, couldn't travel the distance they needed to travel, and so I always felt there were a lot of barriers, and I felt like a home-based version would be one of those ways to combat a lot of those barriers. I worked on my master's and really kind of focused on home-based rehab when I was getting my master's in 2015. So that's how we kind of got things going. As well as virtual visits were really kind of being promoted at Kaiser, and so this is kind of one way to kind of fit in with that. So.
Cool. No, that's good to know. So both of you had, you saw patients struggling with coming, the transportation, the distance, the co-pays. How do you go from this idea of we should look into home-based cardiac rehab to actually getting leadership to actually do this and sponsor it? If you could just share that experience, I think that would be something that would be helpful, because I've talked to a lot of people in this room, and just getting upper management, going from kind of at the ground level getting up is kind of hard. So can you share what tricks or what strategies you use to get them to care?
So my practice director always had an interest, and she has a background in cardiac surgery nursing, and was, I had worked with her years before trying to get a pulm rehab and cardiac rehab program off the ground. So she was definitely an advocate, and because of I think the atmosphere with virtual visits, I think that really helped. Kaiser was looking for innovation, and that fit that bill. And we were going to save a lot of money. So I think that's huge.
So I guess what's the first conversation? So did you go to your practice director first, or could you go with?
Yeah, so I talked about the research that I was doing for school with her, and at that time she was meeting with different regions in an innovation meeting, monthly meeting, I think, and they were talking about cardiac rehab, doing home-based cardiac rehabs. And Kaiser Northern Cal has had a program, actually a remote program, for 20 or more years. It was part of a study with Stanford called MultiFit, which then basically evolved into Moving Analytics. And so there was also already a precedent for it, and they were having success. And then Southern Cal was starting their own thing, and Denver was looking at something as well. So the time was right. So.
Yeah, and just to kind of focus more on the tactical, so when you went to your practice director, what's that process then when you had the conversation with her? Did you have to do a business plan? What was just that internal process at Kaiser to get this implemented?
Yeah, so once we could tell that there was going to be some backing for it and there was some momentum there, we started to come up with a business plan, and we were talking with you guys as well, and getting some help there. But that process took us a long time.
How
And
long? How long?
About 2 years. And we were looking for where we were going to save the money, how we could demonstrate to the organization that we could decrease readmissions and decrease procedures, and found that it was really hard. We struggled with that for a long time. And in the end, after spending a lot of time doing that, we didn't need that as much as really just showing that we could save the organization money. So
it seems like for your organization, and Kaiser, for people that know, Kaiser is kind of an interesting system where they're both the insurance company and the hospital, so they don't care about external reimbursement, and they just care more about quality, reducing costs. And so I guess for you guys, it seems like the business case for doing this was more reducing the cost of sending people out.
yeah, and increasing quality, because now we had our eyes on the patient and we were directly involved with them. And, if things went wrong, we are right there with the physicians and we can talk to them easily about what changes needed to be made or what we needed to do. So those are both considerations.
Cool. Thank you for sharing that.
Yeah.
So Anne, let's move to you. So I remember we met at this conference like 45 years ago, and we had a conversation around home-based cardiac rehab. How did you take that conversation internally, and what was the process for you to get this into your system?
Yeah, so for us it was different because we had a strong traditional program already in progress, and so I expected it to be all about the money, honestly. I expected it to be about the business plan and the ROI. But when I went to my director with the idea of, and we don't do strictly home-based, it's more of a hybrid program, the conversation was really more around patient satisfaction. We have patients that are waiting, I hate to say it, but 2 to 4 weeks to get into our program, and these are people who are out of the hospital ready to go, and we were really talking about how can we get them started sooner and increase their satisfaction as well as physician satisfaction. We were getting comments back from physicians and calls from physician offices saying, why does my patient have to wait so long to start cardiac rehab? So really the conversation ended up being more around that and less about the money. And we also looked at patients who were just falling off, saying, I'm not interested anymore after a long wait. And if we could recoup even that one visit per week, that was still, around $500 per patient that we were currently losing. So I think, similar to what you're saying about innovation, though, when we looked at our organization's strategic plan, they were really including in their strategic plan direction toward innovation and technology. So we could kind of say this also lines up with something within the strategic plan that the organization is focused on. So that was really where our conversation went.
So it seems like for you, part of the conversation and getting leadership is aligning this project with their own strategic plans, which is kind of innovation. And then the business case for you was more patient satisfaction, especially with the wait list and just in general, their experience with rehab.
And I mean, that of course translates to patient quality and clinical quality because we aren't losing patients who really need our services.
Sure. Cool. Thanks for sharing that. So I think one of the things that I get asked a lot is reimbursement. So in both of your cases, your home-based program is not reimbursed, right? And, Medicare today does not reimburse home-based cardiac rehab. But one of the things I wanted to just point out very quickly is that Medicare reimburses for a lot of things you do in a home-based program. And I would find a way to get the slides to everybody. But There are new codes for things like transitional care management. So this is think of what the phase 1 cardiac rehab teams do, where you educate patients around cardiac rehab and you get them into that first orientation. You can get that reimbursed for. There's, giving patients devices like the blood pressure cuff, the scales, the Fitbits. Medicare actually pays for that and can allow you to be reimbursed. There's also doing things like the initial evaluation, where people come into like a cardiac rehab center or doing a 6-minute walk test that can be reimbursed. So different components of home-based cardiac rehab can be reimbursed, and the reimbursement is evolving. So I think over time they're going to get better. So that's just one thought for the audience. So kind of when you were ready and you got the buy-in to implement a program, kind of what resources did you feel you needed to get one going? Both from a human, technology, how are you thinking about what resources you needed to implement a home-based program?
Staff, for sure.
Okay.
And then equipment, of course, which isn't much, but it was wearables, Fitbits is what we chose, and then some of the equipment you were talking about with the blood pressure cuffs and the scales. And we are doing some of our day from home, the case managers. We do a lot of our phone calls from home, and then we come in and we see patients for an intake. So this is something we hadn't thought about ahead of time, but we did end up getting monitors and laptops and phones for our home working. And then, of course, we took we needed an office too in our very small space, and we took our practice director's office, which is kind of sad, but it was very, very nice of her to give that to us. So I think those are the main ones.
Okay. And for your staffing, how did you figure out like how much staffing you needed, and did you hire like full-time staff? Kind of what was your thought process with the team?
Well, we got guidance from you guys on that, and we felt like we could start with one person, but it'd probably be better to start with two, especially if we had to backfill each other for vacations and things. We also have an MA that works with us who does a lot of the tech work and calling patients and getting them enrolled, and she's been great. And then, of course, our great medical director who has been wonderful and very involved in helping us create protocols and policies and things like that.
For sure. So, Anne, let's go over to you. When we were thinking about getting this going, what resources did you feel you needed?
Yeah, so our resources didn't change, honestly, very much because we already have an active traditional cardiac rehab program. It was really a matter of determining who would now manage these patients who weren't coming in, 2 or 3 days a week on a regular basis, but still needed to be managed. So, my first thought was we don't need any additional resources, but then I realized, there's still all of the documentation that goes along with, because we're still getting reimbursed, through either CMS or commercial payers. So we still are required to do the same kind of documentation in order to get that reimbursement. So even though the patient may only be coming 1 day a week, which is our model, they still have to be managed like a patient who's coming 2 or 3 or more days a week. So, the staff that we currently have, the clinical staff, we're willing to take on those additional patients. The numbers have not been high so far. I do anticipate that as we ramp up in numbers, we'll have to adjust our clinical staff to accommodate those additional patients. So the one resource, if you will, that has been really important to us is one person who kind of acts as our lead, I guess, coordinator, if you will. It's not an official title, but one of our staff members who's very tech savvy, very organized, and who was willing to take on the task of really enrolling all of the patients and monitoring the dashboard on a regular basis. So the way that ours works is that patients may be in any of our existing classes, even though they're coming 1 day a week. So we might have one person who's managing the documentation and the follow-up of that patient, but this coordinator, if you will, is the one who's watching for any communication that's coming through. She responds to that communication. If it's something specific to the clinical management, of course, she shares that with the case manager for that patient. So I guess our resources haven't really changed very much from what we already had in our traditional program.
Yeah, I think it just seems that the only difference is having like a point person who's that coordinator who's really owning that role. And I think that's important. What we've seen just from working with, I think, about 25 health systems now is it's really important to have dedicated roles to implement a cardiac rehab program. You have the coordinator that's more setting people up. You have, if in Heather's model where it's a completely home-based program, you have a different care manager who's doing all the ITPs and the patient education, and you have a medical director. And once everyone has their own roles and responsibilities and they stay to it, you can have a very productive program versus one person doing all three, and then they start to fall through the cracks.
Just to tag on to that, so when we started Moving Analytics, everyone was very interested and everyone wanted to train, and Harsh and Linda can support me on this, but everyone wanted to train and everybody wanted to do it. So we trained all of the staff, and really what happened was that because no one had that many patients, a lot of people kind of fell off. They weren't that comfortable, or they forgot their password. So in our case, it's really worked well to have one point person who really sort of coordinates all of that.
Definitely. So the next question is, so you're implementing a hybrid, and we've kind of talked about it, and you're implementing a completely home-based program. So can you just, I guess you can give us like a high-level overview of the workflow. So let's go from meeting patients, maybe bedside, to coaching them. How does that work for you? And then for Anne, it'd be good to also do the same thing in terms of patient comes to an orientation. What does the program entail?
So we bring them in for an intake visit, and it usually takes probably about an hour. We've gotten it down from an hour and 2 hours to an hour and a half to now about an hour. And we set them up with the technology, and we determine, we do a 6-minute walk with them, vital signs, and kind of determine where their level of fitness was, what they were doing prior to coming to us, and also looking at their diagnosis. And then we send them out with an exercise prescription, a resistance band, and a book, an education book, and set them up for weekly phone calls. And we do that for about a month, and then we go to every other week after that for the next couple of months, and then they get to have access to the app for the rest of the year. And we'll be calling them about once a month after that. So anything else?
Yeah, so let's talk about ITPs, and how do you do an ITP in home-based cardiac rehab? How does that work?
So we've worked with Moving Analytics to get an ITP that we have patients fill out several forms like a PHQ-9 and a GAD-7, and how much social support do they have, and rate your plate. And we have gotten it so that we can put all that information into Moving Analytics, and then that will generate most of our report for us, our ITP, except for even heart rate, target heart rates and stuff we've got in there, so it's nice. And then we take that document and pull it into Epic. And so, and then we send our ITP off to our medical director, and then send 30, 60, 90-day reports to her as well.
Cool. And one more question is, what is a home-based cardiac rehab session for you? What does that conversation look like with the patient?
We're checking in about whether, how did exercise go? Did they exercise? How long did they do it? Did they have any symptoms with that? We do the diet coaching in the first phone call, actually, so second visit with them, and kind of come up with some goals that they can make around their diet if they need to. Most of them need a few goals, but a lot of them are really have made a lot of changes already. And then we check in about whether there's anything going on with them as far as stress or depression, anxiety. Are they taking their meds? Any problems with those? Side effects, and then we just kind of, if we need to, we interface with our physicians on that, and that's kind of the basic pattern for most calls each week. and try to encourage them if they're falling off their exercise, because sometimes after a few weeks they're kind of they get a little busy, they get back to work and they aren't exercising quite as much, so you have to kind of just get them back into it.
Sure. And one question I always get asked all the time is, how do you make sure people are actually doing the exercise? Like, yeah, the Fitbit, they can probably put it like on the dog or something. So how do you actually make sure that they actually do what you tell them to do?
I just, I ask them what it is they're actually doing, and then they do report, we get them to report resting heart rate and peak heart rate, and so that information is there. And it's really, I guess they could make that up, but that's a lot of stuff to make up. So I think most of them are actually doing it. But if you see them start to drop off on reporting on that, then you do have to it's a kind of a red flag. You have to get them back in a little bit. So.
Cool, that's really helpful. Thank you for sharing that. So, and let's talk about your own program and how that works. From how you even introduce this to patients to the day-to-day.
So since, again, we're a hybrid program, so generally the conversation starts we do group orientation once a week. So when we have that group of patients and we're doing our presentation, one of the things we talk about is the opportunity to use remote technology, and we offer it in 3 different ways. We say, if you're ready to start and you don't have a long wait time, you can still enroll in Moving Analytics, and you can use this as a means to report back to us what you're doing on the days that you're not coming. And it also helps with some people in motivation to continue what they're learning at the center. The other opportunity we give them is if there is a long wait time and they can commit to, we started out with Saturdays actually, if they could commit to a Saturday morning time, they could start right away. We would sign them up for Moving Analytics. They would come on Saturdays until their preferred time opened, and then they would be allowed to transfer into their preferred time. The third opportunity was to, if they had high co-pays or work restrictions or transportation issues and they couldn't commit to more days than once a week, they could just continue with 1 day a week for the entire program. So those are the 3 options that we provide. We give them a form at orientation, and if they're interested in any of those, they complete the form, and then our coordinator, I guess if you will, contacts them via email, tells them a little bit more in detail about the program, and signs them up for the program. So that's kind of how our flow goes. Outside of that, I would say that our assessment and goal setting and follow-up is really just what we do in our traditional program. I would say that their 1 time a week visit pretty much mirrors what you do on the telephone. It's just that it's face-to-face. So that follow-up with them as far as what are you doing for exercise, are you having any challenges with smoking or nutrition or behavioral kinds of issues, we discuss that face-to-face generally, or they can, of course, communicate through Moving Analytics. And then their dietary consultation or any of the other referrals, diabetes or whatever they need, they generally would do face-to-face instead of on the phone.
Sure. So I guess for you, what's the expectation? So patients are still coming back, they do that 1 session, they still do the exercise. What is the expectation of what they're doing at home through the app?
When they have their initial consultation, I guess I missed that part, but after group orientation, we still do a one-on-one initial consultation. So at that time, besides reviewing all of their assessments, they are given their exercise prescription, and that's discussed. So part of that discussion is, that your exercise goal is not to come 1 time a week, but, to also do your home exercise. So that exercise prescription discussion includes the expectations and goals, and then they are reporting in that, obviously, through their remote technology.
Cool. That's helpful. Thank you for sharing that. So how does your own program, since it's independent, how does it satisfy all the CMS criteria for home cardiac rehab? And I have some of the criteria up on the screen, but can you just speak very quickly into how you satisfy all these things?
We do create an exercise prescription that's signed off by a physician, and we definitely talk to them about risk factors. So we determine what risk factors they do have, and we talk to them about those weekly. We do the psychosocial assessment through the GAD-7 and PHQ-9. And outcomes assessment is we're bringing patients back at the end of their 12 weeks, and we are comparing how they're doing as far as what they're eating. So we have them redo the forms, the rate your plate and the psych-soc assessments, as well as the 6-minute walk test.
And I guess you do the 30-day.
And the 30 days.
Cool.
Yes.
So still kind of following the same broad
We
format,
are,
but
even
just
though-
a different delivery.
Yeah, exactly.
Cool. I'm going to skip this, and we kind of talked about this. So I guess when you think about mobile, right, the apps, the devices, what do you think is the big, what's the function or what's the benefit of having like an app, either in your model, because there's some parts of Kaiser that do home-based cardiac rehab, but it's mostly a case management approach, right, where some nurses call in a patient every week, right, but now you have the mobile technology. Can you speak to, is there any benefit to it?
I think people like to see their steps on the Fitbit. I think that gives them some satisfaction that they're getting stuff done and making some progress. I think the mobile app is helpful. A lot of them really like the chat feature. They're able to send us a little message, drop us a little line when it's not our phone call time, and kind of update us on how things are going, or if we need to change an appointment, we can talk to them. So that's a really nice feature. And some of them are really good about reporting what they're doing, and others kind of are less technologically savvy, or maybe they're busy and they don't always want to report what they're doing. So that's kind of a mix. But if we can kind of get them, reel them back in, it is really helpful to see those resting and peak heart rates and blood pressures and weights and all those differences. And somebody can have a weight change of 2 to 3 pounds, and they'll report that, and we can contact their CHF case managers and help them get the fluid off if need be. So there's a lot of really nice things about the technology, for sure.
And I'm curious on what's your own perspective on that.
Yeah, likewise. I think that it's beneficial for the patient and for the staff, I believe. Patients are motivated, as you know, by many different things, and everyone's different, but I think for the patients who choose to do our hybrid program, they're the subset of patients who are motivated by seeing, their own progress and, keeping track of that progress. So for them, I think that is beneficial to see, sort of ongoing progress all the time. For our staff, it's very beneficial because we also see that progress or lack of. And if patients haven't reported in for a couple of days, we can reach out and say, so, do you have questions? Is anything going on? And they also love the chat function as well. They like to be able to have sort of that quick communication. And we're seeing that especially in some of the younger patients, the ones who are used to technology. They really love having that ability to sort of chat with the staff. So, I think it's beneficial both as an adjunct to our program, and it's also been really beneficial for those who choose to just come once a week.
Sure. Awesome. Thank you for sharing that. Now I'm going to skip some questions so that we have the audience have the opportunity to ask you questions. But I guess we've been talking about a lot of positive things with home-based cardiac rehab, and it sounds too good to be true. So what's hard about doing this? What are the challenges you're experiencing? And as you think about going from where you are now, which is kind of, you've piloted this and you're thinking about how to grow it, what do you think is really going to take that isn't there today to make that happen? I think we can start.
I think not really seeing them in person and how they're doing when they're exercising, you kind of just have to take their word for it. So when we bring them into the program, we really emphasize letting us know about symptoms and reporting their rate of perceived exertion and really kind of getting good at monitoring themselves, taking their own pulse, why that's important, and communicating with us when things are happening.
Cool.
Yeah, I think one of the challenges has been, a couple of things. From the patient perspective, I think identifying the right patient for this kind of a program. There's a patient who wants to do this because they are really internally motivated, and they do like the independence, and they still like, they like the safety of checking in, but they like the independence. And then there are patients who, quite honestly, want to say they want to do it because they really don't want to do it, if that makes sense. It's like, yeah, I'll just do 1 day a week, but then they really don't want to be compliant. So I think identifying, we do risk stratification for event, but I think almost like a risk stratification for compliance has been something that's been a little bit challenging for us. The other thing from a program perspective that we found actually quite challenging, because we have already a traditional program and it's, we have a lot of history and it's strong, has really been figuring out sort of the right marketing, internal and external marketing for this type of program. I hear, I tried scripting for the secretaries, and I hear them like they struggle. They don't really want to offer it on the phone because they're not familiar enough. And the same actually with the staff. We just talked about it again at our meeting last week, and it's kind of like, well, when should I offer it? If I have this patient who says they're going to drop out, is that a good time? So, and I take that on. I mean, I feel like we just, we need to sort of tighten that up. So that's been challenging for us, is finding the right way to communicate to really invite people into this option. So that's something that we're still working on.
And I guess reimbursements, that's still a big challenge, right?
Yeah, I mean, reimbursement or lack of is a challenge, but I think because we still, in our model, bring people in once a week, I still believe it's better to bring them in once a week than to have them completely drop off. So, we're not, I think that was another question that came from my team is, are they taking a spot, if you will, because we don't do an open gym concept. So, if we can take up to so many patients, are they taking a spot, and now we have 2 days a week that nobody's in that spot. So that's been also sort of a shift in communication, that this is kind of an add-on, if you will, that I understand and recognize that it's additional documentation, it's another patient you're managing, but it's really one more at that time, and not somebody who's taking a spot where you could be charging 3 days a week. So I would say right now the reimbursement is less of an issue.
Okay, that's good to know. So I guess one last question before we go into Q&A is, now before you chose Movie Analytics, you looked at different options, right? And now there's lots of other companies doing home-based cardiac rehab. What do you think is the key important things to look out for in a vendor? And what was that process like when you looked at all these different options? How did you choose someone to go with?
I think one of the things that we liked was the fact that you could work with more than one wearable. Okay. For us, that was great. That way, if people have an iWatch, they can use your program, or we could offer the Fitbit. We could offer any kind of Fitbit. They could use any kind of Fitbit.
Sure.
And then we're looking at some other options as well now too. So, and I think you had a lot of stuff put together as far as policies and educational materials and training and the dashboard and the app. So you really had a lot of stuff in place that we didn't have to do.
That's helpful to know. Anything else that you think is important for people to look out for as they're making this kind of decision?
I think their response to us have been very responsive.
Oh, yes. Yeah. Moving Analytics has been tremendous in their support. And anytime we have a problem, no matter how small, they're always willing to help us out with it. And very friendly and very available.
Thank you. So, Anne, what's your perspective on that?
Yeah, so as you said, we met, I don't know, several years ago, and if there was competition at that time, I probably wasn't aware of it. So But what impressed me was, even though I think you'll agree you're both like tech people, Linda's kind of the clinical expert, what I was impressed with was how intent you were on learning and understanding our field, because I will speak for myself. I'm not a tech person, like I don't have an IT background, so I need somebody to provide that. But the fact that you were then trying to so well understand our field and what is it we need and what is it that would make this work, I was impressed with that. I mean, you would come to the meetings not just to be a vendor, but to sit in the sessions and really understand what our field was about. So that impressed me right off the bat. The fact that you were willing to come to our site or, do video conferences and help my director understand and our senior leadership understand the ROI to doing a program like this was really helpful too. You were always available and ready to, provide what do you need. So that was also very helpful. Also, I would echo what Heather said. You've been very responsive. I love that you listen, what's working well, what's not working well, and you regularly check in on that, and then you're responsive to that, we're working on this. What do you think about this? We're going to add this. So I think that responsiveness has also been wonderful to work with.
Awesome. Thank you for sharing that. I think as a company, it's our mission to get more than 70% of people to do cardiac rehab. So whatever it's going to take, we're going to do it. So let's please give the panelists a round of applause. And we have about 10 minutes, so we're going to do Q&A. So if you have a question, please raise up your hand. And Harsh, if you can help me with the mic, that'd be super helpful. I guess I can bring this mic closer, because we have 2 mics. So if you have a question, please raise your hand.
Hi, quick question. So does moving analytics actually provide the blood pressure scale and all of these equipment? And is it, and all the data wireless sent to you guys so you can see it? How does it actually operate?
Yeah, so we don't make this blood pressure card for the scales. We find the best ones on the market that wirelessly transmit the data, and then we provide that to you. So we give you a list of these are the best ones, and then you can choose which one you want to use.
Hi. Do you have to have a separate physician, physician referral?
For home base? Okay. Now I need to find a way to give you a mic. Okay, you're going to go back and forth. See.
So we currently have a referral for virtual cardiac rehab and one for sending patients out, an external rehab referral. But we are looking at combining that so that we can really review all of the patients that are referred and grab the ones that are appropriate for our program and hopefully take most of those patients and still offer the external to people that need it. So.
And do you have a different perspective on that?
Yeah, so for ours, we revised our current referral form and we put in a sentence about home-based or the hybrid program. And so we put in something about if my patient meets the criteria, and then we provided that to all the physicians that they may also participate in the home-based cardiac rehab. So we combined it in one referral.
So when you get the referrals already there, it's already
Yes.
back if they would.
Yes. Mm-hmm.
Cool.
They can opt out, but nobody has so far.
So, Harsh, you're going to have to run back and forth a lot.
Got my steps.
Do you risk stratify in regards to who qualifies for the patient, and do you ever see a way to implement this for pulmonary rehab or have any plans to do so?
So, oh man, this is going to be brutal. Okay, so I guess one thing we can do is if you stand up here, there's a mic here.
Okay.
That way Harsh can just keep that mic in there.
Okay, sounds good.
If not, he's going to get too much exercise. Thank you for doing that, though.
So we do risk stratify. We keep our high-risk patients in the center-based programs, and we have a VAD program, so those patients definitely go to a center. Heart transplant, lung transplant goes to a center. People with potentials for ventricular arrhythmias would go to a center. And then also if they can't use technology, if they don't have a smartphone or an iPad or something, or if they, Moving Analytics does have, they can switch over for Spanish-speaking patients, but that's the only other language. So if they speak another language, then we don't have them enroll in the home-based.
What's the initial cost for the, oh, I'm sorry.
We do the same, we risk stratify as well, and so patients who are in those risk category, high risk categories, or same if they can't use mobile technology, they just come to our traditional program. We have not implemented it for pulmonary at this time. I don't think it's ready for pulmonary, right?
Yeah, we're working on it.
They're working on it.
So,
What is the initial cost for the program? Is it like you buy a licensure and once you have it, or is there a cost for every download of the app?
yeah, so the way it works is there's two models that we have. So one is you can license the software, depending on how many patients you want to enroll. So if you said for the next year we're going to do 600 patients, then we'll charge you a license fee. And then we have a second model that's more of a service. So some people who don't want to implement the program, but they want people to do home-based cardiac rehab, so you can actually refer the patient to Moving Analytics. And so for that, we can charge you like a separate fee. So there's two different structures, and it depends on your hospital, what kind of insurance you're working with, and our partnerships. We're happy to talk about that more.
Is there an average cost per patient?
So for the software side, it's like about $300 per patient,
Okay.
and then for the service is closer to $1,500 a patient.
How do you satisfy the CMS requirement for a physician to be immediately available and accessible for your homebound patients?
That's a big one.
Yeah, so we don't get reimbursed, so we don't have to worry about that.
That may have answered my question, but I was going to ask if either of you are billing out any of those CPT codes that were up there? Neither of you are? Okay.
Not so far.
Okay, thank you.
We can't because our patients are technically enrolled in a cardiac rehab program, so we can't, we still use a bundled charge for ours.
Turn that back.
I'm curious to know about EMR integration. You mentioned the chatting option. Is there a way to save that into the medical record as PDF or discrete field or anything like that?
How do you guys do that?
I have copied and pasted some conversations. I don't do it very often, but if it's relevant, like they're talking about their symptoms, then I will put it into Epic.
Any other questions? All right, that's one here.
So there is technology out there now for people to do EKG monitoring through their mobile devices. Are you going to be able to integrate that into your program at some point in time?
That's a good question. I think when we look at the literature, having live ECG monitoring is, for low to moderate risk patients, is not required. I think it definitely helps to give you a level of assurance, but it's not required. And that also makes it very more complex to implement a program. I think for the high-risk patients, when you look at people that have heart failure or AFib, you definitely want to do that. So as we start to support those populations, we plan on incorporating those kind of technologies.
Last question.
Okay.
I guess I'm just not understanding the reimbursement, no reimbursement, and we have all these CPT codes.
No, so I guess the reimbursement is evolving. Obviously, this is, in general, healthcare is moving to telehealth, right? So every year, new codes are coming, and a lot of the new codes also have a lot of restrictions. So now the new codes that came out, that are going to be available next year, and some of those codes that we showed on the slides. So that's why they can implement those codes now. So I think it's kind of like an ongoing conversation with Medicare for home cardiac rehab itself to get its own proprietary reimbursement. And then there are other things like the chronic care management, the remote monitoring codes. So it's just a very evolving field. And as we learn more, we try to share that information. All right, last question, and we'll call it a day.
So I understand that you guys don't have to do the physicians at will because you guys are not doing reimbursement. Do you guys actually have any clients that are? How are they circumventing the physicians?
So if you look at someone like Anne, right, that already has a traditional cardiac rehab program, she's the same. You can speak
So
more to that.
you know, our patients come in once a week, so when they're there, that's the only time we charge. So we have the physician supervision at the time that they're in our center. The other times when they're reporting in from home during the week, we don't charge for.
So there's no actual clients that are essentially all home-based that's been able to be reimbursed?
Yeah, so we have clients where we have relationships with the insurers in their own states. None of them are here today that do that.
Which states are you guys from?
Illinois.
Oregon.
And we have reimbursement in Pittsburgh. But even in those programs, they have a medical director, right? Like Dr. Gray is a medical director. She's here. So what she does in terms of oversight is she approves all the treatment plans. Every 30 days, she gets a progress report with an updated treatment plan that she provides the oversight for. And if they run into issues with a patient, she gets a call and she deals with that. So the oversight is still there. She's not physically in the rehab center. So thank you everyone for coming. I hope this has been helpful. If you have more questions, you can stop by our booth. But thank you so much.